so proud to be Haitian because just everything about being Haitian is just awesome.
Everyone know about the history of Haiti, first Black independent country in 1804.
Understanding the history of Haiti, Haitian people, you can't help but be proud of the accomplishment that have happened.
Haitian Americans have done really well in the past few years. There's still a lot more work to be done. Only about 20% of us actually have a bachelor's degree.
I understand firsthand some of the challenges that Haitian American students, graduates, and professionals have faced.
Some of them have overcome incredible adversity.
Both immigrated or asylum seekers or refugees.
There are not that many Haitian-focused scholarships, but like any other award, the NAHP Leadership Award is providing recognition for one's hard work.
As we know, college is expensive, so this scholarship fund provides the chance for a brighter future.
It felt like the universe was speaking, like I needed the money, I was intrigued, people were telling me to apply.
Going to college or graduate school can be very, very expensive. So donating to a scholarship like this would help that expense be more manageable.
Future generation of leaders, scholars, entrepreneurs,
young adults that are trying to make something of their lives.
They are rock stars. They just need the help, and they need us to help them accomplish it.
There's like this Haitian proverb that says, "Meilleur pied palu," many hands make the load lighter.
Log in and you can donate $10, $25, $50.
It makes me think of the Malcolm X quote that education is our passport to the future, for tomorrow belongs to those who prepare for it today. It makes me happy to know that our organization is contributing to that goal, preparing others for the future.
Hello, everyone. Welcome, 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 wherever you're watching us from. My name is Mitsuka Attys. I'm a newly minted lawyer who graduated from the Benjamin N. Cardozo School of Law, and I am so happy to welcome you all to today's symposium, where we will be discussing specifically the Haitian community's susceptibility to chronic illness. Now, we have a panel of seasoned professionals here with us who are all doing great work in their respective fields, and I'm going to allow each of them to introduce themselves. So I suppose we will start with Marline. Can you please introduce yourself to the audience?
Absolutely. Thank you for having me, most importantly. My name is Marline Edmond. I am born and raised here in Elizabeth, New Jersey. I am a certified, master certified health education specialist. I usually am a public health professional navigating the health tech world through health communication. In the fall, I'll be joining students at Howard University as I pursue my PhD in health communication. So I'm excited to be here and to share my knowledge and as we continue to advance our Haitian community and our leaders. Thank you for having me.
All right, thank you for that. David, let's move on to you.
Thank you. And I'm truly excited to be here, truly honored for the opportunity. I'd like to, well, first, I was born and raised in Haiti. I grew up in Haiti. I came here 12 years ago. It's going to be on Monday, actually, I think. So I look forward to celebrating that. But it's truly been great being here, learning and going. I currently serve as the Assistant Vice President at WJ University Hospital in New Brunswick, New Jersey. And I do have a nursing background, work as a healthcare administrator currently, and also work, I do also have a company that focuses on creating training modules for health organizations all throughout the country. So our areas of expertise really has been health equity, along with really understanding diversity, equity, inclusion from an organizational standpoint, and really understanding how do we further advance health equity for all. So I'm truly honored and humbled to have this opportunity, and definitely look forward to a very dynamic and engaging panel. Thank you all.
All right, next we are going to move on to Theresa.
Good evening, everyone. My name is Theresa Alphonse. I am the founder and executive director of a nonprofit called What's on Your Mind. And our mission is to normalize conversations around mental health, particularly in communities of color. I'll probably get more in depth as the conversation goes on and exactly how we do that. I am also a program manager for a actually international now hospital system where I focus on Medicaid programming through a health equity lens, as well as focusing on social determinants of health. So I'm really happy to be here. Always great when you get to fellowship with Black people, Haitian people in particular. So really honored and really excited for this conversation.
Thank you for that. Next, we have Chloe.
Hi, everyone. I'm Chloe Burke, and I founded Preston Strategies, and I focus on diversity in clinical trials, and that really is in 3 functions. So the first, really looking on ways that we can counteract historical mistrust in our communities. Secondarily, making sure that diverse doctors and research coordinators are included in the clinical research. And thirdly, making sure that the data is increasingly more equitable. So making sure that we're accounted for and making sure that we know about new treatments, because it really can close some very serious gaps in our community. So, and I look forward to this conversation today. And thank you all for inviting me.
And last but not least, we have Joy.
Hi, well, thank you. I'm Joy Michelle Williams. I am the founder and CEO of Soul Joy Wellness, where we're focused on health and wellness in the Black faith community as well as community at large. So really, I started this because I was really athletic and very in shape at the age of 23. And then I was diagnosed with atrial fibrillation, which if you're unaware, is irregular heartbeat, not caused by valvular issue. I mention that because there are a lot of drugs on the market that support that problem, but usually people who are diagnosed with that are diagnosed at the age of 50 or 60 plus. But as I said, I was 23. So I attended a lot of health events and found that we have a significant number of health disparities throughout the entire Black community, and that we aren't necessarily aware of them and how to counter those. So some of them are because of what we do, and some of them are because of the system that we're in. So that's what Soul Joy Wellness does. It educates people, helps them to get healthy, and helps them to be better advocates for themselves and others. And basically with health, we're focused on faith, fitness, and fun. And thank you for letting me be a part of this conversation.
Awesome. Now, before moving forward, we would like to specifically thank the partners of NAHP, specifically Chocarela. Everybody knows about who they are. En pile l'amour, en pile respect. We thank you for streaming this on your platforms as well. We'd like to thank College Cafe, who does a great job at supporting NAHP as well. We would also like to specifically thank Book It Right Accountancy. And before moving forward again, we want to also encourage you all to donate. We don't mean to throw this at you early on in the symposium, but we want you to understand that a lot is at stake for people's education, specifically for the education of Haitian youth. And so we want to encourage you to donate whatever you can to the scholarship fund. You can go to nahpusa.org, and all the links that are pertinent to the specific scholarship and to the specific fund, you can find it there. Now, without further ado, let's get started. We're going to dive into these questions. So the first question that I have for you all, and this is a question to everyone, feel free to answer. We often hear about individuals in the Haitian community battling high blood pressure, what we call tension, or diabete, diabetes, or sucre, as my grandma would say it. And considering the prevalence of these illnesses, what are the barriers, if any, that exist to educating the community about prevention and having them take the necessary, steps and make the necessary changes to ensure long-term positive impact on their health?
So I can take a stab at that first. I think one major barrier is definitely access to healthy, nutritious foods. So a lot of what you eat really influences your health outcomes, and specifically to the diseases that you mentioned, diabetes, hypertension. And as we know, the neighborhoods that a lot of Haitians, minorities, low-income folks, and I don't want to put those people in a bucket because, of course, we know that there are Haitian people who are affluent. So when I say this, I'm saying generalizations and not necessarily individual experiences. So when we talk about food access, a lot of Haitians live in neighborhoods where they're experiencing what we call food deserts. So lack of nutritious, healthy vegetables, and also affordable. Right now, we're seeing that as an increased kind of barrier with the cost of everything rising, food included. So I would definitely say as just one kind of barrier, and I'm sure my colleagues will list several others, but just access to foods is super important. And I think it's important just thinking about strategies to overcome that barrier. It's about really changing the context in which people can make healthy options. You can't blame an individual for making the option of choosing McDonald's over input any healthier kind of food option if they don't have the option to make those choices within where they live. So I think that is certainly one barrier.
I'd love to. Oh, go ahead.
No, I'm happy that Theresa mentioned food deserts, and one thing that came to mind is the opposite of a food desert, which is a food swamp. You know, we're seeing food swamps, and what is a food swamp? We're seeing a McDonald's, a Taco Bell, a Wendy's. We're seeing chicken tracks on every corner in less than a mile radius. So although there's a food desert where people lack that transportation to go to the nearest supermarket, which may be 3 miles away, they have access to foods that aren't healthy because it's around the corner, a few footsteps away. So I've noticed certain communities where they are tackling the local bodegas to provide marketing such as we accept WIC, EBT, and encouraging bodegas to have healthy, such as fruits and vegetables and healthy products. So definitely food swamps.
And to jump in on that, some people don't even call it a food swamp anymore. They call it food apartheid because the suggestion of a food desert is that it's naturally occurring. And the reality is it's not. These were planned things that happened, that we have less access and there are things less available to us. So that is how we have less access. But when we recognize that all of these things have happened to us, it spills over into other things. So we have less access to culturally competent care as well. So people, we know the percentage of Black health professionals is lower. So the odds are that when we try to see a Black health professional, they're swamped first, right? And then we have to know someone who is culturally competent and understands what our situation is and understands our particular culture, because we like to dump all Black people together, and there are some differences, right, that we need to acknowledge and that your health provider needs to know. So I think that's another barrier, is that actually having competent care that understands how you live day to day instead of just trying to change it to something else.
I think that's an excellent point. Culturally competent care also means knowing how we move in the world, the sort of stresses that add to our environment and that naturally lead to something like hypertension, but also knowing the realities of the way that we socialize and move is constantly surrounded by food. And that's the way that in some ways we express love. And so reorienting that, a healthcare provider who fundamentally understands this isn't just about my healthcare, but actually changing the way that we move in the world, the way that we socialize, the way that we interact is really important.
Yeah, I'll definitely take it a step further. I think these are some wonderful points made by my colleagues. But I think especially, I'd like to take a step further by really outlining the drastic difference, particularly for those that have migrated from Haiti directly. I think that, and I use my mother as an example, who actually does suffer from type 2 diabetes and also hypertension. So one of the things that I've noticed has been really the challenge and really supporting her in behavior modification. What I mean by that is that culturally, especially in my case, I can speak for myself. I'm not saying this general for the Haitian community. I grew up in an environment where I ate rice every single day, and I ate you all know du sauce pois, and you may have it Monday through Sunday. You just have a different type of protein that goes along with that, and the Haitian community would have, just for myself, I would have bread for breakfast, and having, obviously some sugar, I don't say unhealthy, but essentially high sugary items, whether it's, having pasta for lunch, having bread for breakfast, and you turn around and have rice for dinner. So I do think that so we have all the sugar, and particularly for those that, as we get older in our careers and we're spending time working, we spend less time exercising, and we also do not have access to a primary healthcare provider in a lot of cases. So I think in addition to, of course, the structural components that result into those disparities and that really create those barriers for the Haitian community, along with other members of the Black community, to have access to care, I do also believe that our overall culture and some of the things that we grew up loving, for me, I'll speak for myself. I had a conversation with my mother, and I said, "Mom, you know that you're type 2 diabetes, and it's probably would be helpful, and you've been staying with me for the past couple of months, to not to eat certain types of bread and just to modify your nutrition." And her literal comments to me were that, "Well, do you expect me to stop living?" And I was flabbergasted, because I'm thinking to myself, just because I made that one suggestion of really modifying her nutrition, it was so personal to her, especially at her age, that she felt threatened. She felt like it was a life-threatening statement, right? So I do think that a part of it is also addressing our youth and really helping our culture understand the importance of healthy dieting. And I'm blessed to say that I can make better decisions in terms of what I eat and where I eat. But I would say that although we don't have food deserts in our community, my mother, and again, it's just kind of like, I'm not speaking for the entire community, but we have a lot of our communities who would still insist on their behaviors and how ultimately we're brought up as a people. So, if you look at our country, if you look at those that have migrated here, we still see those patterns and those trends, regardless of access. Now, I'm not saying that access is not an issue. I'm saying in addition to lack of access, we have those issues as well.
Awesome. You all make great points. And one thing that I realized that each of you kind of touched on is that sometimes it goes beyond kind of individual behavioral change. And I know specifically in public health, those of you who are familiar with the field, you guys may know that there's something called the social ecological model of health. And specifically, the next question that I have is particularly for Theresa. Being a public health professional and you understanding this kind of model, what do you think can be done on the community level, on the social level, to truly have, to truly make these changes so that people don't feel burdened, I guess, by the individual changes that they make? Is there anything that can kind of relieve that burden on a community level? And for the rest of the panelists, feel free to jump in if you have anything to add as well.
Yeah, I think there needs to be further emphasis on the social determinants of health, which is exactly what that model really references. I think within the Haitian community specifically, we think about health as really physical. And I think culturally, our understanding of when we go to our provider is just when we're sick. And I think it speaks to just the lack of accessibility to healthcare providers. We know that there are low rates of providers in general, let alone culturally competent or culturally humble ones within the country. And I think that definitely follows suit when a lot of people migrate to America, and just not understanding that provider is also there to support you in terms of prevention. So oftentimes the concept of going to your provider on a regular basis before an ailment occurs is something that's extremely foreign. But then beyond that, again, I think a lot of folks touched upon eating and diet and how that impacts your daily living, understanding that exercise impacts that too. And if you don't have access to a safe space, greenery, to be able to do that, that has a huge impact on your overall health. I think we're in a space where we're starting to have the conversation really about like employment and how safe your job is, as well as how much it pays, and knowing that there is this correlation between poverty level and health outcomes, as well as the mental health conversation. So I think it's really important that us in the healthcare space start to look at people as whole people, as opposed to just looking at the physical, and then also thinking about root causes for things. So oftentimes when we're talking about social determinants of health, in my workspace and just putting on my hat of working for a hospital system, we're talking about like transportation. And I think, you know, that's great. It's nice that we can connect with Uber and Lyft and we have these programs to bring our patients to X, Y, and Z. But even within that, sometimes we're limited to just going to appointments. And it's like, just like provider appointments. But what about appointments with the Department of Transitional Assistance? What about appointments with all these other factors, housing, infrastructure, to be able to support the overall health? So I think when we really want to get to the root cause of why we're seeing these disparities outside of implicit bias, which is like a whole other conversation, it's really about, we have to be in the conversations when it comes to increasing our minimum wage and having livable wages. We need to be able to chime in and have conversations about how us as public health people can have cross-sectional dialogue with people who are employers. And how do we create a system as well where we empower individuals? And that's another thing I stress so much in the work that I do, is how do we bring people to the forefront? I think everyone on this call is in a space of privilege in some sense, because we all have all these letters behind our names. We're all in a space where we're safe, where we're warm. Some of it, I'm a little too hot because, you know, my AC is not all together, but that's a personal problem. So like, we come from a sense of privilege. So in a sense, we're a little removed from the communities that we're even talking about right now, whether we experienced it when we're younger or not. I don't think anyone on this panel is living that. So I think including the voice of the community every step of the way is also important when we're trying to pull in all these sectors and all these voices to be able to create a change in how people are able to navigate the world when it comes to their health and beyond, because literally everything is connected and everything drives your health.
Right, that's great. One thing that you noted, that you kind of noted at the end, you said that we should be looping in the community and making sure that they have a seat at the table. So the next question I want to ask to all of you guys is, in our community, a lot of the times, there are conversations that weren't had, and a lot of the times, personally, I feel that a lot of individuals, Haitian individuals, they sometimes feel as though they're kind of like a victim to the system. They always feel as though something's happening to them. They can't really take charge of their health because they don't feel as though they're in charge. So how do you think, in your professional opinions individually, how do you think we can change that? How can we make different Haitian individuals in our community feel as though they are partners in their health, rather than feeling as though it's almost like something is happening to them and people are making decisions for them?
I would love to answer that question. And I think what it comes down to is, as professionals, that we are plugging in our community. And what I mean by plugging in is that we ourselves act as a resource. I mean, that's something that I'm doing daily. Something as simple as helping my mother walk through disability forms, identifying and understanding that my mother's health literacy is not as proficient as mine, and understanding that only 12% of our, our population here in the United States, according to the CDC, is proficient, in health literacy. And they've made those modifications in the most recent Healthy People 2030, right? So understanding that there's two components. They've identified the personal health literacy, and organizational, which is that we as professionals should be able to give others access to information so that they can understand. And one of the few things that I do, sometimes I could be walking down the street and someone from the Haitian community will say, "Oh, that's the person that's part of the Haitian community. She's a resource." Petit film, aidez-moi avec ça. Besoin de moutem, de smooth that. And then, sometimes right then and there, m'appelez un papier bayo. And then it's just like, and so it helps them feel empowered, or sometimes I'll get a random call from my mother and she'll say, "Vous connaissez un tel besoin aide avec this." And then I'll say, "Well, I can't at the moment, but let me connect you with one of the faith-based Haitian organizations in the community. If this person is new to America, they need to make this organization a priority and understand that place is a walk-in location. It's open for them and it's a home for them. It's a safe space for them." So directing them and navigating them to different places and understanding that health literacy is at stake, but as I'm empowering them, you can see that they're able to take in that information and share it with the next person, and let them understand, like, okay, this is the proper way to go about it. Or, you know what, I remember this person helped me and they directed me there. So it's there's that hand-holding in the beginning, but it's that proverb where just like you're teaching that person how to fish, and now they're helping others and empowering others to take control of their health decisions, and increasing their health literacy and advocating for themselves. That's another thing that I'm pushing others to do, is like, I'll ask them, who's in your home? And when I say who's in your home, do you have a niece that you're living with? Do you have a granddaughter that you're living with? And then I tap into that generation and let them know, like, hey, be there for this person, and understanding that part of that health, them making that healthy decision in their life, is having that support in the family and within the home.
I'd love to add to this as well. I think both Theresa and Marline brought up some excellent points, but this also is really a focus of, we need to think about long-term of how do we sustainably build trust in our community, not only from the industry, but how does this come from like upstream all the way upstream. So when we think about infrastructure dollars coming down, how do we have sustained conversations in our community that healthcare doesn't just have to come from traditional healthcare systems, but that information can also come from other sources. Like, this source also matters. It's also increasingly clear in our communities that health insurance is not enough. Health insurance will not be enough to address the health disparities that we see from a race-based advantage. And we also need to look closely at like confronting the institutional racism that we see in healthcare systems. That means policies, that means norms that just sort of attract natural race-based advantages. And so just to be like really concrete of some clear action items people can do on the line today. For example, my space, I work on clinical trials, and some of the things that we're working on right now is specifically diabetes and hypertension. But if you know someone who doesn't have health insurance, if you know someone who hasn't been to the doctor in a long time and there are no clinics in your area, find one of these clinical trials. There are literally experts in this space who want to work in our communities. It may be a good resource for you to be able to have a temporary insurance and actually get access to a medication that will actually work for you now, or that is innovative. And so action items of get involved. I remember in the early phases of COVID, particularly in our community, when we needed vaccines, we sort of helped our grandparents, we helped the neighbors, et cetera. I'd love to see that same structure rebuilt sustainably over time with all sorts of healthcare initiatives.
Such a great point by Chloe. And I think I probably just want to add a little bit more onto that in terms of really putting the pressure and advocating on behalf of the Haitian community to get healthcare leaders and organizations to really make a commitment to addressing those health disparities within the community. One of the things that I found to be extremely, I would say, impactful has been the intentionality of healthcare organizations to create programs that specifically address the social determinants of health, whether it's I would say think about income, right? The socioeconomic status. So one of the things that we've done at one of our hospitals I've worked in the past has been going out into the community, identifying members, and really providing them with the training and ensuring that they have employable skills that they can actually be employed by either the organization or all the partners within the community, such that as a full-time employee, Now that person now has access to health insurance, and they also have access to a better quality of life. And so, so we've done things addressing the socioeconomic status. We've done, of course, transportation. We've talked about that, Theresa. In addition to a number of things that really push leaders to understand those types of gaps in terms of care outcomes when it comes to the Black community in general. So I think one of the things that, where we have an opportunity to do a little bit better is really being around the table. And oftentimes, the voice of our viewpoints and those of us who are very close to the community, we fail to represent, I would say, the needs of the community. And sometimes it could be because we're a little bit distant. And but I know that one way to address that, and one way we've done, especially in healthcare, we've created different advisory committees. We've looked at internal advisory committees when it comes to hospital leaders and other employees. We've also looked at members of the community where we can actually work very closely with and have them provide their input. And really, what are some of the issues that are pertinent and unique to that particular community, and what can we do as leaders, as healthcare leaders, to begin addressing those things? Things such as even affordable housing is now something that organizations are actually investing in. How do we build this new center where a person doesn't really have to go out to the hospital for care, but now we get to have a primary care provider available on site, in addition to a number of other factors that affect their overall health behaviors, in addition to providing them with housing, employment, a number of social factors that could result in improved overall health outcomes. So I do think that, of course, that comes with financial investments, but of course, understanding the numbers and really being able to show, of course, is the right thing to do. But beyond that, showing the business case associated with living a healthier lifestyle. In fact, we spend more money as a healthy organization and patients with high ER utilization, they have to come to they have to use the emergency room as their primary care providers, right? So it makes sense, not just from a most case, but also from a business case as well, to help our communities live a healthier lifestyle.
So I'd like to add, I think my colleagues have all said great things. From the faith-based and community perspective, one of the things that we need to do more of is to give the people the feeling that they are empowered, so that to give the information. Sessions like these are great, right? When you join in with what your community organizations are doing, and your faith-based organizations, and your churches in particular, your churches and other faith organizations that do a variety of things, and where people are constantly in communication with those organizations. And for some of them during COVID, they stepped up and did things that where other people wouldn't. A lot of, if you look across the areas, a lot of churches were sites where people were receiving vaccines. So if we start thinking that we can get information, like one person mentioned earlier, from other places, and that we can let people know that they have the authority to be in control and to hold their legislators accountable. Like, it's not just about voting. It's those people should know who you are as a community, and they should be responsive to the community. And I think some of that, and I know me, I think I've become more active in the last 5 years on a political level, but I think, some of us, we're recognizing what's happening around us. Because even though when we talk about the social determinants of health, is, where you sleep, where you work, where you play, where you go to school, those things. So the disparities that we're experiencing don't go away when you make more money and have health insurance. So that we all have to think this is impacting us all, and that we need to be empowered to make a change. So I think those community involvement can be very helpful.
All great things, all great things. I want to switch gears a little bit. Specifically, I'm going to start with David for this question. We've all heard about health equity, and to an extent, I feel as though health equity has become like the new buzzword, right? So some might say, people just throw it around, not really understanding what it is. But for you particularly, and then I want to hear from the rest of the panelists, what does the achievement of health equity look like practically in your professional opinion?
I think that's certainly a loaded question, but I'll certainly try my best to answer that. And please, anyone else, feel free to actually weigh in. I believe so. My understanding of health equity is really pragmatically removing all barriers that which may prevent one from reaching their full health potential. And so, and we talked about this, a little bit during the panel in terms of whether it's socioeconomic status. We talked about access to care, and just preventive measures, et cetera, and in terms of nutrition. So a number of components that are actually present in the community. How do we, as a healthcare leader, so those are my lenses, as a healthcare organization, as a healthcare leader, how do we create different measures that can actually impact and help us overcome those trends and those disparities? And I really like the point that was actually made earlier as well, regarding not just the understanding of the social determinants of health, but also understanding that structurally and systemically, we do have structural issues that are related to racism, implicit bias. Of course, we also have overt biases that are actually affecting some of those outcomes. So I think it goes back to really providing being culturally competent. We talked about cultural humility as a major component as well. Having the providers understand the value of going beyond just care and expertise. No one cares that our hospital and our services are ranked number one in the state. Really, that's irrelevant to the community. What really matters when I go into a hospital, when I go into an environment, I really want to know: can you care for me? Am I going to be safe? Can you understand my needs? Do you understand my some of the things that are unique to my community? And oftentimes, we see that a lot of hospitals, at times, are known as some of the best that we ever see in our country, particularly some of the ones that I've worked in. But I will say that you find that the community feels a lot more comfortable in places that we call community hospitals, because that's when there's a connection. That's where someone who's Haitian may go into that hospital and they may find a provider who can speak their language. We having the appropriate language services. So when I think of health equity, I really think about all these different factors, and even when it comes to understanding it's essentially removing barriers, whether it's even collecting the right data at the point of entry. So we collect race, ethnicity, language data, preferred language data, making sure that we can identify any trends in that data and identify a way to overcome those disparities, whether it's looking at even LGBTQ plus status, looking at preferred name, looking at the transgender community. How can we overall make sure that when someone gets into the hospital, that ultimately they're treated with the respect and the dignity that they deserve, and beyond that, we're not missing anything at the point of entry. So it's a very comprehensive process, and I think someone may have mentioned this earlier as well. It's looking at the person as a whole, and I do believe that each facet of our society plays a role in advancing health equity. It's not just a healthcare issue. It's certainly not just political leaders are not simply the ones that can actually advance this, but every company, every entity within our communities, essentially we have a commitment to improve health for our communities in general.
I'd like to respond to this as well. So one of the things that I do outside of how I introduce myself is also coach organizations, particularly hospitals, health centers, around how to achieve, because I don't know if we can necessarily achieve it, health equity, not to sound negative, health equity through a racial justice lens. And I think a few folks touched on implicit bias, but I want to talk about it a little bit more deeply. I think in order to achieve it, it requires an eradication of implicit bias. So the understanding that providers, or really anyone who touches point with a person, if we are talking about the person interfering or interacting with several different systems, really eradicating implicit bias from all of those systems and really eradicating it from the structural level is what we would need to achieve. I think one of my colleagues put it nicely in that even if someone is rich and has access to healthcare, there are factors that are determined by their intersecting identities. So whether they identify as LGBTQ, whether they're able-bodied, whether they're Black, what their ethnicity is, their first language, they are going to interact with the healthcare system in a way where they can really be oppressed because of whatever that identity is. And if we could get to a place where everyone could check their biases, and it will take more than training. I know a lot of healthcare organizations have implemented cultural competency training or implicit bias training, but I think it really goes beyond that. I think that is just kind of the first drop in the ocean, so to speak, because it really is a lifelong journey to be able to unpack bias. And I think it requires folks to want to unpack that bias for them to achieve being able to really operate without it, or with a lens of acknowledging it and saying, hey, I think this decision was influenced by this experience that I had. And I like to talk to people about even just my own experiences as a Black woman with my implicit bias and how that has been projected on other people. And oftentimes when I speak about my experience, people are like, oh, wow, like I experienced that too. And I will say that, like, even just growing up Haitian American, being born here, but of Haitian descent, I've had to unpack how I even look at Black people in this country and how I treat people who are not of Caribbean descent. So I think being able to be honest with ourselves, to be able to unpack that beyond training, and then thinking about how we integrate that into policy as well. So it's very, very difficult to be able to sue a hospital provider without the overt act of racism. And we need to create policy that allows us to be able to really look at implicit bias as racism and as something that is harmful, because we know that it is. And that's why we see a lot of disparities between different races, despite socioeconomic level, despite education level, because providers are actually treating us different. And there are a slew of experiments, there's a slew of data. I really would like for our system to push past the data collection piece and really operate as if they exist, because it does exist. There have been experiments done really coding the language of how providers interact with white patients versus Black patients. And all across the board, time and time again, there's less rapport building. They're using more medical terminology. They're a lot more cold, and they're not really trying to connect with patients in a way that they do our white counterparts. So I think it's up to our hospital systems, our clinicians, to like just act as if it already exists so that we can begin to dismantle it, because the proof is in the pudding. Like, the history shows us, the data shows us that it's there. Like, I grew up always thinking about this quote, not to get like religious or anything, but I'd rather live my life acting as if God is real, and then, just finding out that there's no heaven or hell and just, being done, versus living my life thinking that God isn't real because it doesn't harm, it doesn't hurt. And I think that's how we should be looking at our system, thinking that implicit bias is literally integrated in how we analyze data. It's integrated in how we interact. It's integrated in which organizations we choose to fund. So I think the acknowledgement that that's there is crucial to achieving health equity.
Well, I'd like to jump in on that. And thinking of quotes, one I think from Frederick Douglass, like, power sees nothing without demand. So the system isn't going to reform itself just because they're feeling good about themselves. That's not what happens, right? These are even non-for-profit health systems have other things that they're going for. And I think that we have to, one, make sure that we are aware so that we can try to make changes in the moment that it's happening. Because instead of talking about how we're collecting data of terrible things that happened, it's how can we stop this in this moment? So in the moment, sometimes you need another provider. Sometimes you need to let your insurance company know that you don't want them to pay these people because they didn't take care of you. Sometimes you need to talk to the hospital advocate. So those are some of the things. And then to realize, when I think of celebrity stories, and I tell celebrity stories because I think it resonates with people, like Serena Williams has a story of when she was giving birth, and Allison Felix has a story as well. So when we look at these this happens to celebrities who had enough resources. And basically Serena saved her own life. She diagnosed herself. She told them to give her a test and they were like, no, you don't need it. You don't need it. Because I think what happens to people and what happens to other people talking about this, they want to talk about the history of us distrusting the healthcare system. I don't distrust them from 100 years ago. I distrust them from yesterday. So we have to recognize, like, what do we have in our power and how can we make it change? And how can we stop going to physicians that are terrible and nurses who are terrible and, and anybody else in that system that's terrible, because that's what happens. And there's so many good providers, but you want to know when you're in crisis, because we want to, one, stay out of the healthcare system if we can, but we're in crisis. We want to know that people are listening to us on an individual basis. I don't want to be grouped into the socioeconomic, whatever data that you're talking about. I want to say, this is what's happening to your body right now, and this is what you're doing, and this is how you interact at home, and we're looking at you. And I think there was more talk a few years ago about precision medicine, which I was excited about, because if we're looking at the individual, then that would be helpful. But there's less talk about that now. But we, as the people who are suffering from all this health disparities, have to really make the change.
I'd love to jump in there a second. I think you brought up some excellent points. Among them, and really important for us to keep in mind of the upstream, is like medicine in itself is a highly homogenous field serving diverse populations, and that's a problem. And inherently, it becomes difficult to understand the mindset of a patient you are not, and that you do not know, that you do not interact with, and that you are having struggles to empathize with. That in itself is a larger cultural context that needs a lot of work. But to your question, for me, health equity, first of all, health in itself is a big word. And for me, it's about being able to reach your potential unencumbered by all of the things that are happening around us. It's about improving the clinician's understanding of the patient's life outside of the hospital and outside of the clinic. It's this seamless blurring of the lines between the hospital, the clinic, community organization, and the patient themselves. For me, that's what health equity in its fullest potential looks like.
Wow. So I kind of want to merge what you said and also what Joy said, because it's a perfect segue into my next question. Specifically, we've talked about health equity and each of you have mentioned something about it, but this question is a two-part question. What role should healthcare practitioners play in addressing, and responding to healthcare disparities in a culturally sensitive way? And to Joy's point about, Serena Williams and how she really had to take charge of her own health in that moment, what are the red flags that you think that people individuals should look for in terms of particular professionals or healthcare practitioners that are not culturally sensitive? And if they do find themselves in that position, what are the ways in which they can advocate for themselves?
I can actually start with that, especially when it comes to the advocacy component. I really like Joy's point about really how do we really stop the harm from actually escalating, from getting any further, right? And having to so one of the things that we've done, and I think when I say we, I mean the hospital that I've worked at. Of course, having a hotline, it's definitely, I think, patients understanding their rights is number one priority. And I know that at times, based on the community, at times, there are communities that go into the hospital and they don't have their discharge instructions or their documents being given in their preferred languages. So I do think that's actually an opportunity for a start, that regardless of the language you speak, we do have technology now where we can, in fact, we should be able to translate all documents within a hospital system and allow patients, regardless of their languages and their barriers. As a Haitian person, if I don't speak English well, then I should be able to go in and see something I can identify with. In addition to that, I know that because of patients' rights, and because there are a number of policies that are in place, even at the state and federal level, that require hospitals to really give patients an opportunity to disclose any discriminatory issues that they have. But oftentimes, many organizations actually keep that as a hidden practice. So it's not clear to me, if I didn't know healthcare, or if I didn't know that aspect of healthcare, it's not clear to me that if I'm discriminated against, then I can in fact call somebody within the organization, or or make a formal complaint to the state, and also from a federal level that can actually be addressed, and where the organization can actually be reprimanded. So I think building more transparency when it comes to that, ensuring that our patients are educated, knowing their rights, and beyond that, really holding leaders accountable. And so I think one of the things that I've seen, especially when it comes to those patients of color, it's all people get a pass when they make a mistake, or when they drop the ball when it comes to patients of color. Of course, part of that is that there's a lack of diversity in the leadership teams, right? So you always have an understanding that, or things tend to mostly favor the perpetrator, and oftentimes the perpetrator looks like the leaders that are leading our systems, and which in a lot of cases they're 100% white. Of course, I'm not advocating that there's anything wrong with any particular race, but our community should reflect, the leadership team should reflect the communities that we're serving. And if you look across organizations all throughout the country, of course, a lot of organizations may argue that they have a diverse team. What that really means is that when it comes to the entry-level positions and the positions that are preliminary and that are early careers, it's diverse. But really, when you start looking at directors, AVPs, and above, then there's very little diversity, which makes it very challenging to have those viewpoints that we're actually discussing and reflect those things in our policies, all throughout the organization. So my takeaway from that is, one, there has to be a concerted effort and having a systematic change, and really looking at policies, looking at equitable policies, just like we would look at pay equity. And so we have to look at policies that can be equitable and favorable to the patients. And beyond that, have very clear processes that patients can utilize to report, and to also directly impact the scores of hospitals. I know currently patients do have an opportunity to score their experience when it comes to after leaving the hospital, but not every patient receives that survey from Press Ganey. So that has to be, whenever there's a cultural issue, whenever there's a racial issue, I do believe that those initiatives should be implemented to allow to allow organizations to enforce organizations to have a zero tolerance policy when it comes to inequities and racism, discrimination, etc.
I'd like to add from the side of the patient. So as a patient, we have to start from the perspective of, your doctor is not Jesus, right? So that we have to start from the perspective, right? The doctor is not. So they are fallible, and they might not even making a mistake. But if you don't understand what the doctor is saying, then you need to ask the doctor some questions. And then the other thing I think that we should do, we should look for second opinions earlier on. So I remember I had, this is more than 10 years ago, I had a problem with a tooth. And I went to a dentist who decided that I needed a root canal and I needed to have a crown. And I'm like, I don't have any pain in this tooth. And she's like, well, the insurance is going to be high. It's going to be whatever. I'm like, I don't have pain in this tooth. I just need this filling to be refilled. So I went to another dentist for a second opinion. He's like, why are you coming for a second opinion? I said, because I have a heart problem. My cardiologist can explain to me why I'm having what I'm having. My dentist can't explain what's happening to my tooth and why she wants to do this really invasive procedure. And basically, I didn't have it. So I'm saying it was more than 10 years ago because I still have the same tooth. I just got the filling refilled. right? So we have to say, whatever they say, we have to question it. We have to use what we think, and not to be disrespectful to people, because they did go through a lot of training, but ultimately at the end of the day, they could be wrong, and you can have another course of treatment. And she was saying this is her treatment plan. But in all things, and we should not feel that we're being disrespectful to a physician or a dentist who's saying that to us, and that if they feel that way, they weren't the physician for you anyway.
I would like to jump in and add on to what you're saying, because everything you're saying is great. And one thing that I had to do is help my mother change her mindset, because what I realized as I was taking a deeper dive in how us as Asian people look at health, what I realized is that our people do not question those with authority, and doctors fall into that category. So they feel like, okay, so na l'école que médecine pour un diplôme non moi-même c'est malheureux pour que ça peut monter question. So I had to let her understand, like, Mom, if you go get your car fixed, isn't that the mechanic providing you a service? So when I would tell her, this is the same thing as a physician. They're ultimately also providing you a service. So what we'll do is we'll sit down and together, so that, because we know that sometimes the visit may be 30 minutes, or it may not even be that long. But we'll sit down and, okay, what are the questions that we should ask this physician? So getting her into the habit of understanding that I'm here to advocate for you, but you also must advocate for yourself. What are your concerns? And what I would notice is that a lot of our people, their concerns has a lot to do with employment. So it's just like, okay, if I have this condition, how long will it keep me out of my job? You know what? Mbafel. Because if it's more than 2 jours off, that means that's 2 days out of my check I'm gonna miss out. Et puis, kop kailan gen pou voye lot semen. And that's what they're thinking. And it makes you stop and think, oh my gosh, wait, we have a bigger issue here. So that sense of advocacy and understanding, okay, what aligns with how can I meet my mother where she is, but also as a community, how can we meet them where they are, and understanding that advocacy component, and understanding, like, okay, let's sit together to write down these concerns, and let's hold our physicians accountable just as much as we hold the clerk at the post office, or the cashier at the supermarket, or our employer that lower check loans or no check no good. You will turn back and tell the employer, no, you missed a few hours from my overtime from the week before. We need to continue to encourage our elders, our parents in our community to advocate themselves in that way, by shifting them in that perspective.
I'd love to add to that. Those are some excellent points, and some very clear metrics for me is, does the healthcare provider see me? And I think that's something that you can sense really early on. Do they see you? Are they empathetic? If you're not comfortable asking questions, something is wrong. Maybe consider bringing someone with you. In this age of virtual format, maybe a family member can't physically come with you, but you can ask the doctor in advance, you would like to have a hybrid option so that your family member is also holding you accountable. Is your pain being trivialized? When you explain it, did your doctor exaggerate? Is he under-exaggerating? That may also be another marker. Are you being interrupted? Are you being interrupted consistently? That may be another flag. But mostly, do they respect you? And is the care being provided cognizant of your reality? So if you're worried about multiple days off, if you're worried about actually being able to keep up with the healthcare plan they proposed, actually consider whether that doctor understands the reality outside of that space. And if not, you may need to consider someone else. I recognize that's not always possible. It's not the job of the oppressed to explain to the oppressor, but if you are stuck in one of these situations, then require more of him and outline what you're working on.
Agree with all the points. I will also just say, grievances. A lot of times our people, if they have a negative experience, they just switch providers. And there's no way that that hospital, that clinic is going to know that there was a negative interaction unless you file a grievance. And hospitals have to let the state know when those grievances are filed and have to communicate those, and are not happy when they have grievances. So I think oftentimes, I think other folks alluded to, you have to really hit the hospital systems where it hurts. And I think that's one way. So I would say that. And then also just really quickly, I wanted to talk about green flags. I think folks did a great job of identifying some things that, raise red flags with their providers. But I have an amazing PCP that I've had since I left pediatrics, and I'm really sad that he's retiring. But one of the things that I really love is that he's very much culturally aware of my culture. And when you walk into his office, he has paintings of Haiti. He's able to talk about places that he's been to in Haiti. We're able to like have dialogue about food, and it just makes me feel like very valued and respected. I'm not gonna say I'm a hypochondriac, but I will say that I'll think that I have things. I'll go, just do a Google search and say, hey, doc, I think I have X, Y, and Z.
Google will tell you you're dying.
Right. And anything I ask him to do, even if he does not believe in it, he does it anyway, which I really, really love. And we know, even if he's maybe like referencing his notes, but I love that when he comes in, he's like, hey, how's your job? And he'll name like the exact place that I work. How are things going? Are you adapting well? Before we get into the visit, because then it makes me feel, just at ease, because that space, oftentimes, like once we get to our provider's office, maybe we're rushing, I tend to be late for a lot of things. So I might be frantic because I'm late. So he's able to like bring this calming presence, which relaxes me and thinks about who I am. Again, kind of the theme of what I've been saying, beyond just a patient, but we really build a rapport. And he asked about my parents and just people that he knows that I value in my life. So I would say find a PCP that embodies all those things if you can.
And if you don't mind me asking, is this PCP, is this like a private office that you go to?
Yes, this is a private office.
Okay, so I feel like that kind of leads me into the next question. This next question is something that was posed by an audience member, somebody who's watching. And actually it's two different questions from two different people, but I'm going to merge them together. One question that was asked is, can we as a collective create our own healthcare system similar to how other cultural groups, or similar to how the Jewish community has done? And also someone asked, is there a directory of providers who are culturally sensitive that you can recommend? Does anybody want to take that?
I'm happy to take a portion of this. So I'm based in Miami most of the time, and we're actually building out a competent list of basically diverse providers. And so once that's up and ready, I'm happy to share for those who are based here. But there's also a great app called Health in Her Hue. And you can actually filter through by race, frankly, and even gender. And I find that to be quite helpful. And there are also a number of reviews. So those are two great resources. So one, happy to share. And I think my website has come up on the screen. But secondarily, also consider the app Health in Her Hue.
Okay, and David, do you want to take the question regarding creating our own healthcare system, since you did mention, that we do need to see more of us in leadership positions?
Yeah, sure. And I think, the location actually, matters as well. And I'm not sure if the question was pertaining to Haiti or if it was here in the United States. Of course, naturally, my inclination is to go to Haiti and think about those terms. But certainly, those are not easy questions. I mean, I think that obviously, healthcare is very complex here in the United States as well. The payment processes are very complex. So I do think that, a start when it comes, a first start could actually be creating, and I think the comment was made about the Jewish community and how they're treated and perceived within our healthcare system all throughout the country. I think a similar model can be adopted as a first step. And having Haitians that are engaged, that become advocates, that meet with those healthcare leaders, that become community leaders, and really start influencing the decisions that are made at the top. And I think the most, I would say, the most frequent way that I've seen it done thus far, I'm not saying that's the only way, is really start engaging in some of the, those boards, throughout healthcare, right? So joining for example, may join a board of trustees and beginning to take part of the conversation, beginning to discuss and have conversations with those different leaders, and really figure out how we can implement measures that are culturally sensitive to the Haitian community. One of the things that I've seen, I think, even in the communities that I've lived in, a lot of times we tend to have culturally sensitive care only in communities that are, I would say, not as affluent when it comes for the Haitian community. And I think that should be a different model, which as Haitians and as members of the Haitian community, whether first, second, third generation, we should be able to go to an environment and to the point that was made earlier by Theresa, and feel that this provider, actually, I can identify with this provider. But the last point I'll say about that, in terms of building a healthcare organization, I think it goes back to funding, goes back to having investors, building the networks, building the relationships, and having a network of individuals that are actually willing to invest in this overall initiative. Certainly, I think as Haitians, we oftentimes tend to. I'll take that. I would say as Haitians, as our slogan would say, "L'union fait la force," and I do think there's opportunity for us to actually work better collectively and work better together. So whether it's the Haitian diaspora all throughout in all the countries all throughout the world coming together, putting together a plan, I think that we'll have a tremendous opportunity if we wanted to hypothetically build a hospital that's very similar to the ones we have here in the United States. We have the leverage and the opportunity to do that. We just need a dedication from leaders. We need people that are actually invested in, and we will need the fund. And whether it's here or anywhere else, funding is extremely important when it comes to healthcare. And unfortunately, what I've seen, and I'll be very frank, as a healthcare administrator, when we have those conversations, it always goes back to the bottom line. Yes, they're there to we're there to improve the community. We're here to help the community, and ultimately it goes back to, well, how do we keep the doors open? How do we go back and how do we we're looking at our operations, we're looking at our margin, how do we increase more? And again, it's almost, and I know it can be challenging to think about it in those terms, but I do think that having there's always the payer mix that we got to think about. We got to think about, okay, well, for those that some may have the charity care, some may have the other health insurance models. So how do we have a comprehensive way where we can actually have a balanced sheet that can actually ensure that a hospital remains open? So I do think so. I'm saying all that to say that I do believe that the financial component is extremely important. I think that we have to figure out a way to generate the funding, whether it's through having investors, having people that could actually help us in putting that together, and really just having leaders that are dedicated to the cause, whether it's here or elsewhere in Haiti. Again, I don't think there's a simple answer to it. I certainly don't have all the answers. It is certainly a dream of mine to go to Haiti and build a hospital and work with leaders to do that. But I'm certainly not, I would be very, very, transparent in saying that I know what I don't know. And I think as leaders, really having that humility and making sure that we have the people that are expert in those fields and come together and making it happen. So, but the financial component is a tremendous part that would have to be addressed, and that would have to be done through donors, having a strong board of trustees that can address those factors.
Well, we do have a network right here with NAHP. So listen, if you have to reach out to anybody to make that happen, feel free to. Chloe, you look like you're about to say something.
Yeah, I just wanted to add here, you don't need to be a doctor just to be able to support building this collective of a healthcare system. If you are an educator, that means you could likely break down information, complex information, in a way that's digestible for our community. If you are a person who is a super voter and is out there doing campaign season, you are exactly the person to talk to legislators that this is how a local doctor in our community can get a PPP loan to be able to expand their practice and service more people who look like this. There is a sector or a portion of it that you can grab today, grab that, and that's how we build a collective.
Awesome. So the next question that I want to ask, I'm glad that you mentioned healthcare communication, because this is kind of A little bit more of a fun question. If any of you are Haitian, I'm not sure if you're first generation or second generation, all of you know the obsession that our Haitian parents have with WhatsApp. You probably receive a quote from your grandmother or your mom every single day. I know I do. I had to turn my WhatsApp notifications off. So my question right now is, we're currently living in a data-driven world. I mentioned what I said about WhatsApp, and I'd like to know, in your opinion, what are some innovative ways that we can use our knowledge about social media to get accurate and necessary healthcare information to these individuals, specifically those of Haitian descent? And what do you think is the future of data in healthcare? And how can we harness the right data to improve healthcare outcomes for our community across the board?
I'd like to take a shot at that. WhatsApp has been amazing in the community engagement work that we've been doing here in Elizabeth. And when I say amazing, because we were able to engage over 900 people in the census due to WhatsApp and YouTube. We were able to, as an organization, the faith-based organization that I worked with, Jefferson Park Ministries in Elizabeth, we were able to come together, create a YouTube video, and disseminate it to different channels, whether it's WhatsApp, Facebook. We use the Facebook Live platforms in collaboration with Haitian Flag Day Planning Community New Jersey to do lives to educate people. We've tapped into local Haitian influencers to share vaccine education information. We develop content using softwares like Canva. We're using different sources, different tools, to whether it's developing content, disseminating content, tapping into creatives or curators that they know. And the future of what that looks like is that continuing to use Haitian platforms and media to channel that information, whether it's through Haitian Times, we've worked with in the past, we don't tweet out who we've worked in the past, and maintaining that communication, also exposing them to those channels so that they know other forms of Haitian media outlets that they can tap into. So, but definitely WhatsApp, because through WhatsApp, we were able to tackle different challenges in health communication, which was the misinformation and miseducation of information. So what would happen is that they would send us the misinformation, and then we would follow up with the correct information, whether it was through the CDC or a updated article. So back end, we would make sure that we were up to date with what the CDC's guidelines were, and or our local governor's guidelines were on COVID-19 or on the census, so that we can share that with them. And most recently, for example, FEMA. FEMA had shared information about providing reimbursement funding for those who have lost a life due to COVID. That information came out, and they lashed onto it quick. And then, is it true? And it's quickly we got the information. We pulled up the article, and we would tell them, like, if you see a .gov at the end of a URL, please know this is a credible information, and informing that, so that when they would see a link, they would go and say, okay, let me see if it's a .gov or .com, or you know what, if I'm unsure, let me share it with one of the Haitian professionals within the community who I trust to confirm this information is accurate. And by doing that, we would get this revolving door. You know what? Let me check in with them. And then if it was something else that was inaccurate, we would tell them, and then they would share amongst their friends like, ça va vrai. Intel said if I would bump, Intel. And then by doing that, we encourage them, listen, when you receive misinformation, check in, but also correct other people and say, this is misinformation. Let me provide you with the correct information. So now we're changing the culture around misinformation and health communication, and them understanding what that is. And they're like, oh, you know what? Let me continue to tap in. And by them tapping in and building that trust, we are now creating more advocates and those who can make decisions for themselves and more. So that based off the conversation we've been having so far.
I love that you mentioned that, because it makes me feel as though, with what you've said, we all can truly be a part of all of this. The changes that have to be made are very, very simple. They're not huge changes that have to be made, and all of us can be a part of it. So just remember, you can be a part of this change. although you have all these professionals up here talking, you are part of that change that can be made in our community with regards to healthcare. Does anybody else want to take a shot at that question?
I do, and sort of a different perspective. I think it was great, the information on when we think about how many people are using WhatsApp. And as Marlene talked about, how it's not a thing to them to use it. So sometimes people like to think of themselves as not technically savvy, but I think that the fact that they're using WhatsApp is in fact that they are. And when we talk about data and health, more of that stuff is going to happen on your phone. So you can take your pulse, you can take your pulse on your phone and transfer that data. And I just saw this device that they said cost $90. I'm imagining it will get smaller, that you can do an EKG, which I've read some studies about them being relatively efficacious as the 13 lead or whatever lead it is. I'm not a physician. So when we get that ability to transmit data and we can do that, we'll have more control over what's happening with us. We can see what's happening. There's no reason that we need to wait to figure out what until we see a physician in person to transmit some of this data. So there'll be more data compiled on us individually and collectively. And some of that is interesting right now because Apple and Google are doing things with how they're sharing data, but it's not, again, they're publicly traded companies who's in the business of making money. So I don't know why they're doing what they're doing. I don't think that they're just out to make us feel good. So, but right now there's some other things that are increasing in privacy, but there are also things that are HIPAA compliant that can transmit our data. And that at the same time, because our data is stored now, you can get results from tests that you had. You can find them online so that you can be a better curator of your own information. So I think that's the other positive side, that we can be more involved in our own healthcare and we can know, we don't have to remember what the doctor told us because we can see it. And then we can supply the doctor with even more information.
I'd like to add on to that, being in health tech, it opened my eyes to a lot where now, community-based organizations can now share a referral to their client and their patient right within their cell phones. So that way, they can ditch having to worry about that person losing that piece of paper, that business card, and it's text to them in their right within their language. So it's amazing to see how that's taking place. It's amazing to see how there's tools where people can now see their healthcare prognosis and or just what's going on right through an app, for example, like MyChart. You can have that into your phone. You can see the latest medicine that that your doctor's prescribed, and it's overall giving people that the sense of empowerment that we've been talking about and control over their health.
So specifically for you, Marlene, you're saying that you are in health tech. Do you find that there are ever any barriers to, I know the barriers exist, but specifically, how have you seen the barriers that technology has, created in terms of people of Haitian descent really being aware of what's going on with them, health-wise, and how they can access healthcare information in the proper way?
Absolutely. Technology insecurity. We're experiencing that. You have the baby boomer population who are being left behind. So then they are overall not having access to information because not everyone's depending on social media. Baby boomers, they depended on newspapers, they depended on flyers that were on their tree posts. Now you have communities who will find you if you post a flyer on a tree post, but that was a mean of information, right? You don't see community boards in the community anymore. Now you get an e-newsletter, but if that person does not have a laptop, a device, a computer in their home, they cannot do that. My mom wanted to go see her sister in Florida, and and the regular Wi-Fi, no, and I was like, what? I was like, what do you mean interlogging Wi-Fi? And then for me, I had to check my privilege because I assumed she had Wi-Fi, and I was like, wow, mama me clear pile basket. That was her first thought. She's like, no, from WhatsApp. But that was her current concern. So it just shows you where the gaps are. That tech and security is now slowly becoming a household name. And we are seeing how everyone is focusing more on e-newsletters, social media to get information out. But now you're seeing, again, back to health literacy. Health literacy is costing us money, right, every year, because now people are not receiving the prevention education that they need because of the lack of technology.
Awesome. So I want to switch gears to a question that another audience member asked. This question is specifically for Joy. Are you ready, Joy? Okay, so the question says, there's a large segment of the Haitian population that are active churchgoers and participants. What strategies do you suggest to incorporate fitness and wellness in a faith-based setting?
So I think the first thing is to have support of the pastor. So anything that you do in church that the pastor really supports, not just in name only, right? The pastor needs to show up sometimes, needs to talk about they're doing it. He needs to, take a picture of the pastor doing some fitness activity. I think that's the first thing. And having a health ministry. So a lot of churches have health ministries. There are a number of advisory committees that try to help churches with church ministry, with their health ministries. So there's the Interfaith Advisory Council in each borough in New York. There's the BOM in Gilead, which is it helps nationally. But if you're starting something locally at your own church, is to find someone who is really engaged and excited about working out and excited about those possibilities of sharing with other people. I've done some church challenges, and I'm actually getting ready to do another church challenge. And the team that won the first time that we did it was the team that was already the fittest, right? So they were already excited about activity. One of them was getting married, so that was another bonus, because she's like, I'm getting married, I'm gonna do well. But if you can find things that make it exciting for people, and some of the things we do a lot of praise dance fitness. Like we'll do exercise to gospel music or other Christian music, and then we'll do some things that people can learn choreography, because sometimes people want to be a liturgical dancer and they don't really want to be a liturgical dancer. So that gives them a chance to do a little bit of that. And then fun things, like we'll do drums alive. We'll have an adult play date, which is another thing. So we'll do like jump rope, a whole bunch of different activities that people had given up on, but now we're going to make it a family play date. So there'll be, the jump roping. We'll do drums alive, where you actually exercise by hitting a Bosu ball that's on a bucket, right? And then dance to different music from all over, since our community is very diverse, and that helps to attract people in. So I think, being a little creative and trying to make it fun. So the challenge made it fun because people like to win, they like free things. So if you also provide food at something, healthy food and healthy competition, that will draw people out. And if they have an opportunity to win a prize, it doesn't actually have to be a big prize. It'll get them going even more.
May I also add?
I have that as well. I'm just thinking about different times of year around the Daniel fast that usually encourages people to really reconsider what they're eating and follow the pastor. And so maybe we should think about ways that we can think about a modified Daniel fast and other times of the religious year.
I'll add. Sorry. I was going to say, so I've done some wellness education at churches, and I'll say a couple of things that have worked for me is tacking on the whatever you're doing, like right before or right after within the sanctuary, because then it doesn't give people the excuse, well, I didn't know you were downstairs in the basement, or I wasn't in the building. But having that happen like right then and there, and I've even had pastors give me the opportunity to like make announcements as well, like during the service, and I'm able to plug things in there. I think another thing too is important is to like understand the audience, because we can say Haitian church as an umbrella, but like what kind of Haitian church in terms of denomination, as well as I would even say like educational level as well too. So, and I think that just allows you to provide context on how to deliver the messaging, which I think is super important. I agree with the free stuff, raffles. People get really excited about raffles, and it's funny because you give out the tickets and people aren't sure like where to read the numbers and things like that. But those are some things that have worked for me.
I would also mention intergeneration, right? Getting everyone in each generation engaged and involved. I remember, I believe it was 2019 before COVID, that November, one of the elected officials in a local, in the next community in East Orange, we did a workshop on, diabetes education, but the panelists consist of young Haitian professionals. And for them, it's like a sense of pride. So it's just like letting the parents know, like, hey, your son and your daughter is going to speak, or just overall empowering where they feel, wow, I want my daughter to connect with that professional. You know what? I want to be able to show, like, we can look up to this individual. So there's this sense of pride when you see someone young speaking about something, and it's just like, okay, I want to pay attention, I want to listen, and then there's that sense of throwing in some humor, the proverbs, and another thing that also helps them to connect is during that session, throw some passages in the Bible that reflects on wellness, and let them think like, oh wow, okay, there's that connection between not just wellness but also faith.
One thing that I've also seen some churches do, I know that some community organizations, they often partner with churches where churches have a food pantry. And recently, even I in my own church, I just went to see what they had in the food pantry. And I'm like, they have almond milk now, they have oat milk now, like they're leveling up, they have alternatives. So I truly think that that's another way that they can, that community organizations can partner with faith-based organizations and truly make that change for members of the community. And in that vein, I kind of want to go along and ask another question. You all know that Haitians love to rely on their natural remedies. Everybody knows the power of real mascati. I've gotten a real mascati rubbed down. I'm telling you, it's a life-changing. We have, plants like T-bum and a lot of different natural remedies that we rely on. In your opinion, do you think that the Haitian community has over-relied on natural remedies to their detriment? Or can we strike a healthy balance in the future or even now between clinical involvement and staying true to our roots with natural remedies?
So I think we can definitely find a balance. I think our healthcare system actually should be more educated on natural remedies and really work with patients to be able to incorporate both Western medicine as well as whatever medicine is prevalent within that person's home country. I think that even speaks to how we bill as well, and like what we can be reimbursed for. So within like my advocacy space around mental health, I'm always talking about therapeutic modalities in addition to therapy, because we know there are so many barriers to being able to access therapy. But how about really focusing on exercise, yoga, meditation, etc. And even just talking about how prayer is also a protective factor, and has proven that within many cultures that are Black, that prevents folks from attempting suicide and things of that nature. So I think if we were able to have our hospital systems bill and get reimbursed for things that are within that therapeutic modality or within holistic medicine, thinking about acupuncture, and not just limited to Haitian holistic medicine, but other forms as well, I think providers would be more prone to maybe prescribe those things, talk about things. I think, and that also speaks to like the medical education that a lot of providers receive. And I think a lot of it starts there as well. So really integrating that into the curriculum, and back to the point of cultural humility, how can we treat our patients as experts of themselves And the provider is only the expert of what they know and what they were taught in medical school. And how can we combine those two different kinds of expertise in a way where both are learning? Because the provider is still in a continuous sense of learning and does not know all. So how do we make that connection? I think is really important.
I'd love to add here as well. I think natural remedies has been part of our culture. It's been part of our culture since the beginning of time, but it also is part of the way that we communicate. And so we've been able to share these remedies over time because it's not just the information, it's the source. And so as a person who works in the clinical trial space and really focuses on diverse engagement, for me, I'm hoping that long-term we can build the levels of trust in which it's not just the information, but also the source that shares information about clinical trials. I think it's important to have a combination of both, but focus in a space that's really driven by data. And I think it's really important that we just reframe the relationship and really talk about some of the ways that counteracting the sort of mistrust we've had in the clinical trial space over time. But earlier, to Joy's point, I think she brought up something that was really clear. She said, I'm not hesitant about what happened 100 years ago. I'm hesitant about what happened yesterday. And I think that that's an important point. It's also important for us to become educated on the way that the clinical trial space has changed, what is now illegal, and ways that you have to be compensated. You need to be informed. You can drop out at any point, about being really clear from the outset of what's required of you or what's not required of you. And so I think that there's just really an ongoing need for education in our communities to really understand what has changed, and also really important for healthcare providers not to disrespect natural remedies that have been important to us even culturally over time.
I totally agree. I mean, even during the COVID pandemic, we've seen what our Haitian parents have done. And I know that, a lot of people were putting different fruits and other stuff in like a pot, and they had everyone inhaling it. And to an extent, it worked for some people. Not to say that that's going to be like a tried and true tested way to resolve things, but I have seen it work. So I think you make a great point, Chloe, that we should begin to integrate these methods into our healthcare system. Now, I have a question specifically for Marline and Joy. Either of you can answer it. For a while, many were concerned about the fate of the Affordable Care Act, otherwise known as Obamacare. The Supreme Court recently upheld the law in a 7-2 vote. However, the court seemed to place more focus on the procedural aspect of the case rather than the foundational issues that have sparked so much debate around the Affordable Care Act. What does this mean for the ACA going forward, in your opinion, and for the individuals who benefit from it, and for the healthcare accessibility as a whole? Not necessarily the fact that the court only focused on the procedural standpoint, but the ruling itself.
So, from my perspective, what the court did, it doesn't really matter what they focused on in the immediate term, because it means the Affordable Care Act will be around for at least 2 years. And why do we say 2 years? Because we vote again, and right now the Democrats are in control. The venom around the Affordable Care Act doesn't really make sense to me, but it's there. So people will try to get rid of it, but for now, for the next 2 years, it should be relatively safe. So if in that time we find another way to frame it, and that the people that are against the Affordable Care Act, like, recognize that states declined taking money from the federal government because they didn't want people to have more health care. So they declined the opportunity. They're like, no, we don't want these people who are underinsured to have this opportunity, so we're going to decline it. So for the moment, it still exists, and for at least 2 years we're okay. But there are people who are still adversaries who will continue to fight it. And there are other laws that are in, that have had that same fate. So I don't think anything is in quicksand. I mean, in concrete. it isn't in quicksand, but it's somewhere in the middle. So we can be comfortable for a little while, but we definitely need to be advocates for it. There are different things in different states. In New York, for the past 4 or 5 years, there's been a universal health insurance bill that's passed the Assembly, but has yet to pass the Senate, the state Senate. So it's passed the Assembly time and time again. And I don't know how much you're in New York politics, but there was a time when, the Democrats have been in charge in a court of numbers for a while, but some of that has changed. And even though they could have passed it this year, as far as I know, that I don't think it's passed. But there are other forces that are going to try to keep our systems the way that they are now, because there's a lot of money around here, right? So it is going to be a challenge. But for 2 years, we should still have the Affordable Care Act, or whatever we call it.
Awesome. Thank you for your input on that. We have an audience member who asked another question. They ask, do you think we as a country will get to a point where health insurance will be universal, like in Canada and some places in Europe? I see David gave a little chuckle there. Would you like to say something?
Sure. I mean, and I think, and I chuckle because I know that, obviously it's a very important aspect, and I do hope that that's the case. And the reason why I say that, I know that, in fact, I had an opportunity to speak with a number of my friends from Canada, and who are Canadian citizens, and they were. So we were really talking about the process and the efficiency of healthcare services in Canada compared to the United States. And one of the things that they made mention of was that at times, there seems to have been a longer wait time. There may be some opportunity for advancements in terms of their services, and a lot of the procedures that are highly advanced, they have to come here to the United States to actually have those procedures. So there are positives to both systems, but I think that given the level of expertise that we have here in the United States, the ideal model would be such that healthcare should be adopted for everyone. I think that, I'm sure Joe probably can speak to this a lot more than I can in terms of the Affordable Care Act and expanding the services, through to other states and to the entire country. Of course, states having, the luxury to in fact adopt or essentially go away from that. I think the government, ideally, it would be great if, regardless of your position, regardless of where one stands, that we can all decide that universal healthcare is a right and ultimately not a privilege. So I think there's hope. I do believe that healthcare organizationally still has to catch up. Especially when you listen to his conversations around finance and in debating where we are and how do we meet our bottom line. It can be alarming at times when you look when the focus is really about looking at a balance sheet, looking at the numbers, looking at patients as numbers, as opposed to focusing on the person itself. I think we've gone away from that. And when you even think about healthcare or primary healthcare providers, oftentimes the reason why there's a lack of sensitivity also is because providers are so quick to try to rush the next patient, and you'll see that a lot of the specialists now, a lot of physicians now are going straight into their specialties because they find that it's not as financially appealing to be a primary healthcare provider. So a lot of the roles now are being pursued by nurse practitioners. So there are a lot of things that are shifting in healthcare. Unfortunately, our current model and our system is financially driven, and a lot of people go to medical school to become providers. And of course, I'm not doubting that there's a love for medicine in a lot of those cases, but I think the touch and the focus on the person, and I would say the person instead of the focus on the person, I think we've gone away from that. So before we can even get to the point where we have universal healthcare, we would have to get to a model where the funds that are distributed by the government. We spend a lot of money on healthcare. I think from the GDP, 17% of our GDP goes towards healthcare services. So it's just a matter of how do we properly allocate those funds, and regardless of whether it's a blue state or a red state, we should be able to come together and agree on this one model. And I think that unfortunately we're not there yet, but I am hopeful that one day we'll get to that point and still be able to provide those incredible services.
So I would add, I think it's really incredibly complex, and in the United States, and some of the people that are not for universal health care are people who are in unions. So, and just let's look at the teachers union. I did a workshop, and I had someone present from the National Association for the Physicians for a National Health Plan, something like that. And the room had a lot of educators, and the reason that they're not for it is, and why unions and why Bernie Sanders was trying to accommodate unions, or somebody was trying to accommodate unions, is that their unions, as a part of their package, negotiates for their health care. So they don't want the minimum standard that they think is going to happen. They want the negotiated standard that's higher. So I think that there's some complexity in that. There's some physicians who don't take insurance, and there's a lot of concierge medicine, and some of that is going to happen, and it's going to continue. So the way we have health insurance or car insurance or home insurance is you put money into a pot hoping everybody doesn't need it. So how are we going to allocate this? I do think that healthcare is a right. And the other problem is that people have distrust of the system, and they have distrust of the government. So putting those two things together, some people don't want it because they don't trust who's making the decision whether or not they can have a test, right? Who's making that decision? And I think some people think that that's an easy thing, but when you listen to people and when they talk about their concerns, I think it's complex. I think that it can be done. I don't think it's going to look like what Canada's looks like. I think I definitely think it's going to have some cutouts and caveats for other people, for union employees, and educating unions have a lot of people of color in them. There are other unions that exclude people of color. So I'm not for unions on the whole, independent of just our union, but I think this is what is causing complexity. But we really have to advocate for what it is that we want. And there are a lot of people in New York, for instance, who don't know that this law has been passed from the Assembly several years in a row, and not the Senate, that could be advocating for it on the side if they were really for it.
And quickly, I'll probably just add one additional point on that. I think the other component that could probably help the issue is really increasing transparency when it comes to healthcare services. And I think one of the things that's being looked at currently is when you go into a hospital and you utilize the ER services, ultimately you don't really know what you're being billed for. If you were to go to the ER and you get they'll give you a Tylenol because you had abdominal pain, the next day we'll get a bill for $1,500. So so the provider gets to send you a bill, the hospital sends you a bill. If you see a surgeon, you get a third bill, and all these things are things that that currently our system is actually not structured. And when you think about many of the providers, whether it's specialists or primary care providers, they're not considered to be hospital employees. In fact, they have their own private enterprises and are operating as ultimately profitable organizations, companies, if you will, right? So that has to be managed as well. So to Joy's point, it's extremely complex. And I do think that because of the Affordable Care Act, a lot of hospitals have merged all throughout the country. Even in New Jersey, we have maybe 5 or 6 healthcare systems. And by virtue of doing that, they're able to reduce cost. And the goal ultimately will be to have more providers that opt to become hospital-based providers that are community that are hired by the hospital, which will then allow the hospital to have more control, reduce costs, and ultimately that can also help with making sure that healthcare is a lot more affordable for everyone. Can't hear you.
I'm sorry, everyone. So I was mentioning the time, and I want to thank you all for joining us. But before I let you all go, I do want to ask one last question, being that this is a symposium about chronic illness and the Haitian community's susceptibility to chronic illness. We know that oftentimes chronic illness can be exacerbated by stress, or sometimes it may even, be triggered by stress. So I'd like to ask you all, what are your particular thoughts on mental health and how that can be prioritized? And what advice would you give to people in the community on how they can prioritize mental health in order to lower their chances of suffering from chronic illness?
So I'll go back to my earlier point about just pushing therapeutic modalities in addition to therapy, and just really understanding what it is that we like to do, how do we feel when we do it, and how can we integrate more of that into our lives. So talked about prayer as an example. How do you feel when you pray? Do you feel at peace? Do you feel calm? And how can you integrate more of that into your life as well? And then I'll just do a kind of plug for my organization and just talk about a little bit of what we do. So we provide active listening for folks via telephone, as well as we go into areas that are predominantly minority, to be able to meet people where they're at, to have conversations about their thoughts, feelings, and emotions. And I think being able to have someone to really reflect and talk to is super, super important, and I think is very undervalued in our community. And there's just this kind of exacerbated stigma that we experience in our community with when it comes to mental health. It's very much so, let's not let people know about our problems, or there is some sort of association with things being on your permanent record and things following you, which to an extent is untrue. So I think being able to have those conversations about how you feel, and as simple as like, how are you doing? And having that dialogue that's in a way where you're not just like, I'm fine, thank you, but really being able to express what it is that you're actually feeling, and doing that in a space where you're safe. I think people can then begin to normalize those conversations and really start to integrate that and create some sort of support system to be able to have you continue to be able to do that beyond therapy. But I will also say that therapy is great. Therapy is amazing. If you're able to access therapy, I think that is something that is life-changing. And I like to say that like everybody needs therapy. So don't wait until you are going through something. But I see therapy as maintenance, and people always ask me like, how do you know when it's time to get back into therapy? Because in my experience, I've been in and out. When I get to a point where like therapy is not meant to be forever, but when I get to a point where I feel like I've been given the tools to operate and be functional and be able to maintain myself, I step out of therapy. But then I think it's finding a fine balance of having a safe space to be able to talk about things, but also not to offload your issues onto people. So when I am finding that I'm in a space where I'm offloading, that's when I'm like, oh, okay, I need to get back into therapy, because this is not this person's, they don't need to take on everything that's happening with me. I think just finding that space where they can listen is great, or finding someone to be that outlet for you is great. But once you are really bringing people through the mud with your trauma, I think that's when you need to create those boundaries and get into therapy if you can. So journaling, running, exercising, all of those things are important and cannot be glossed over. And I think we've talked about this a lot, but like doing it in a space where you're doing it with others is important. We are Haitian, and community is so important. So like even with my own family, every Saturday at 1 p.m., like me and my aunts will do like fake Zumba, because I'll be the instructor and I'll lead it, and we're punching and kicking. Or sometimes we'll find a YouTube video I think a lot of folks are relying on YouTube and maybe Instagram Live and things like that to be able to stay physically active and fit. And that community allows us to just get to know each other better, to create new memories, create experiences, and the physical is tied to the mental. So I think finding spaces again where you are doing more of what you love, I think is super important. And it's a way to integrate mental health without being explicit about mental health, because I think, again, that stigma, I used to work in a health center, and once we told patients we were taking them up to like the mental health floor, literally I've seen Haitian patients like screaming like, no, I'm not crazy, don't take me up there. And we have to like start just shifting the language. So even with my organization, when I talk about mental health, I don't even talk about mental health. I say your thoughts, feelings, and emotions. And I think that's what resonates with people.
That's a really great point. I think I do some self-care Saturdays. So the next one's July 24th. The Eventbrite for it will be out tonight or tomorrow, and it's for free. So I think in doing events for people around mental health and around those things and putting all those things together, exactly what you were saying, Theresa, that people don't like the word mental health. So to try to destigmatize it for people and to recognize, especially in a faith setting, that, you know, however God wants to heal you is how he needs to heal you. And you can pray and go to therapy. You can do those things. Yes. And as we come up on next month is BIPOC, Black, Indigenous People of Color Mental Health Month. So we'll talk about that more. But I think to find things that you enjoy and to think about that self-love is self-love and self-care is something that you have to do. I think the quote from Audrey Love that self-love, self-care is an act of resistance, but it's something that we have to do, and that we feel we feel more stress on our bodies than we internally than actually that registers with us. There was some study that I read, and it was like that, you know, that people, their bodies feel it and they say they don't. So we really have to make sure, and this is Black women, that we have to make sure that we're taking care of ourselves so that we're good for the community and good for ourselves, and that we don't become ill and don't suffer from these chronic diseases as much, because we need to take care of ourselves.
And you know, I think, and the quick comment I'll make on that, you know, as one who has worked actually, you know, as a nurse and it's like, you know, mental health, there are times when things do exacerbate, and that you know, we need those services. And I think that especially in the Haitian community, we have to find a better way to educate our community and help our community become more comfortable and accepting of the fact that there are times when we just may need help, and it could be that could go past beyond the therapeutic element, and it requires some interventions for treatment, right? So, and that's okay. And so helping them understand that, helping our community become okay with that, I think is also critical through education.
Awesome. Well, once more, thank you all for joining. We'd like to thank our audience members for watching. We dropped a specific survey link in the comment section, depending on the platform you're watching on. I'm not sure whether it's to the left, to the right, but please check it and give us some feedback. Thank you all, you know, to our panelists for being here today. Thank you for sharing your time with us, for sharing your expertise with us. And right now, we're just going to go around and you each can let us know how the audience can connect with you if they want to hear more gems, if they want to ask more questions. Just let us know how we can connect with you.
So I'm happy to start. You can find me online through my website, www.prestonstrategies.com. My email I'll drop in the chat, which is cburke@prestonstrategies.com. But if you do have hypertension or diabetes and you're interested in participating in clinical trials or learning more about clinical trials, please feel free to reach out to me. And secondarily, I would love to share with everyone a list of doctors in our community, particularly if you're based in South Florida, and the link to the app that we mentioned earlier today. But and the last point I want to leave here is just to remember to schedule some time for joy, and to know that you will grow where you're planted, and so water the soils of where you are.
Amen to that.
I guess I'll go next. You can find me Soul Joy Wellness at all social media. Probably the best thing, Instagram, but wherever social media you'll find me. You can find me on the website is souljoywellness.com. And then if you want to email me, I'm joy@souljoywellness.com.
Anyone want to be next? Marline?
Didn't realize my mic was on. Sure. You can find me on LinkedIn, Marline Edmond, and yeah, that's all.
David?
I'll let the other lady go first.
Okay, yeah.
So kind of you, thank you. So if you'd like to connect with me around my nonprofit work, you can go to www.whatsonyourmind.org. And then if you'd like to connect with me on my personal level, it's theresaalphonse.com. And you can just fill out the contact form and I will respond as soon as I can.
Awesome. And for me, I can be reached at fdavid@trainreversal.com. I actually wrote that in the chat box. Can also be found on LinkedIn, Franck D. Nelson, and or fdavidnelson@gmail.com.
And once again, we'd like to thank our sponsors, Shokaila, for streaming this on their platform and for always providing support to NAHP. We'd like to thank Book It Right Accountancy once again, and we'd like to thank College Cafe, who's usually our sponsor for the college symposium. And right now, we'd just like to plug once more the scholarship that NAHP has. It's our Leadership Scholarship Award. And if you want to donate to the fund, any amount counts. Any amount will help us reach the goal. So I just urge you to go on the website, nahpusa.org, and you will find the information there. And once again, my name is Mitsuka Attys. You can find me on any social media platform, Instagram, YouTube, LinkedIn. Just type in Mitsuka Attys. I'm pretty sure you won't find anybody else with a name. And once again, it was a pleasure being your moderator for the evening, and we hope you have a great evening and tune into other events.
Thank you. Quick shout out to the moderator.
Thank you.
Yes, great job.